Hello, friends. Welcome back to another episode of Theology in the Raw. This is the sixth and final part of our series, The Diversity of Trans. I hope you have enjoyed this series. If you've listened to all the episodes, I highly encourage that you do listen to them all. If you have only listened to one or two, I encourage you to listen to them all. That's the whole point, is that we would get our arms around a glimpse of the diversity of voices in the trans conversation. And there's no way we can capture every single kind of experience. There's way too many lived experiences and perspectives and backgrounds and foregrounds and all of the above. But I hope that these six conversations were helpful in exploring the diversity of the trans conversation. My guest for today is Dr. Paul Ruse. Paul is Associate Professor of Pediatrics, Endocrinology, and Diabetes. If you're watching the video, you see me kind of looking around here because I'm trying to read his profile as accurately as I can. He is Associate Professor at Washington University School of Medicine in St. Louis. Dr. Ruse has an MD and a Ph.D. He is an endocrinologist, and he is an expert in the medical side of the conversation about puberty blockers and cross-sex hormones, which we explained what those are in this conversation. Dr. Ruse did want to make it really clear that his views do not represent the university as a whole. He's not representing the perspective of Washington University School of Medicine in St. Louis. These are his own personal thoughts as an endocrinologist. Also, my book Embodied has been published as of February 1st. You can get it through Amazon. The full title is Embodied: Transgender Identities, the Church, and What the Bible Has to Say. So, if you're listening to this episode because you were drawn to maybe the medical discussion, the scientific discussion about cross-sex hormones and puberty blockers, I do discuss this aspect of the conversation throughout the book. I'm not a medical expert, but I've had to do a lot of research in this area, and that's how I came across Dr. Ruse's very great work. What I love about Dr. Ruse is he's very level-headed, he's kind, he's compassionate, he wants the best of people, and he's also very honest with where we are at with the science in this really important conversation. If you would like to support the show, you can go to patreon.com/theology in the raw, or just look down into the show notes. You can support the show for as little as $5 a month and get access to the Theology in the Raw Patreon community. Without further ado, let's welcome to the show for the first time, the one and only Dr. Paul Ruse. All right, I'm here with an acquaintance / friend. We've met only virtually a couple times. We have some mutual friends, but I'm here with Dr. Paul Ruse. That is how you pronounce your name. Is that correct? You told me. Yeah,
the H is silent.
The H is silent. So, Paul, thanks so much for being on. And I really wanted to have you on because there's a lot of public discussion about trans teenagers transitioning, the efficacy of puberty blockers, the potential side effects of cross-sex hormones, and then medical transition. And this is something you've really become an expert on. And what I love about your approach is you just this is your specialty from a medical standpoint, and so you can just give us the facts. I know in a day and age like today, when everybody likes to claim to have the facts, but as I've looked at your work, you really do seem to just say, hey, here's where the science is at, make an informed decision. But if we're not giving people all the facts, then that's when it, I think, can be really unhelpful. So why don't we start, Paul? Why don't you give us a background of your expertise and how you got into this conversation in particular?
Oh, very happy to do so. And again, it is a pleasure to have this opportunity to speak in this area. I'm a pediatric endocrinologist. I'm an academic physician scientist, so I spend a lot of my time both doing basic science research and also in caring for children that have a variety of hormone diseases. Certainly, a lot of what we do is related to diabetes, but it also includes issues of abnormal puberty and disorders of sexual development, and all sorts of questions related to that. And so I've been in practice for over 20 years. I've been at a large academic institution and have done a lot in my field, to be able to advance science relevant to my specialty. And so that training, I think, has really helped in asking the important questions in this particular topic related to gender dysphoria. I got involved more actively in that conversation while I was chief of our division of endocrinology at my institution. And shortly after I assumed that position, there was really a national conversation that was going on about this growing awareness of individuals that had this discordance in their gender identity and their sex. And really specifically for my specialty, there was a move to engage in treating these affected children with hormones to align the appearance of their body to conform with their gender identity. And it was in the context of that being put forward to start a clinic at my institution for that purpose that I began exploring the scientific evidence that was available about that question and entering into dialogue. And we can talk a lot more about what I've learned over the last decade, as that has been explored. And, what to sum it up very succinctly, there's still so much that we don't know. And so that's really, I think that's why this conversation, I think, is so important, that we have the opportunity to put out there what are the scientific facts that we know and don't know, and what are the questions and concerns that are still remaining.
So when did you said there was kind of a change toward prescribing hormones for somebody, for an adolescent or pre-adolescent who is wrestling with gender dysphoria or experiences gender dysphoria. When did that shift in protocol happen, and why did it happen? Was it based on rigorous scientific kind of discussion, or was it more, I don't want to get over my skis here, or was there some ideological movement that was pushing that change?
Yeah, no, that's a great question. I can just very briefly summarize, that historically, the approach to such individuals that had that discordance between their gender identity and their sex was to really explore and understand, some of the psychological underpinnings of where that identity came from, to be able to support them and help them in that regard. But this new approach to affirmation, rather than challenging that gender identity, it used to be referred to as gender identity disorder. It was recognized as that the underlying difficulty was arising from the thought processes that these individuals had. And I think there was a move. I think it is fair to say that there's quite a bit of ideology involved, and really thinking about that differently. Making claims that really the mind is not a problem at all. It's that the body itself that was not formed correctly. And again, that's not based on any science, and there's a lot that could be said about that. But this is about dating back a little over a decade ago. My professional organization, the Endocrine Society, first came out with practice guidelines in 2009. So to give you some ideas, and they revised those in 2017, and really moving away. So the traditional approach was either to try to assist affected children in realigning their gender identity with their biological sex, or merely watching and waiting. And that was based upon some longstanding data that the majority of children that have this experience, at least when this begins before the time of puberty, will have a spontaneous realignment of the gender identity with their sex. And we're talking, good estimates around 85, 90%. And that was how it was approached in recognizing that. That has moved drastically now to the current approach of affirming one's gender identity and then, engaging in some of these medical interventions like puberty blockers and cross-sex hormones that we can talk about. And it's really moved beyond, looking at the various approaches to very strongly asserting that that's the only viable option forward, the affirmation-only approach. And really with the exclusion of even investigating other ways that we can assist these individuals. It's based medically on the recognition that a very significant proportion of people that have this experience will have real suffering. And I think that that's not controversial at all. Markedly elevated rates of suicide, depression, eating disorders, substance abuse, all of these going on. So the change went from considering this gender identity disorder to focusing on the discomfort that one has in that experience and referring to that as gender dysphoria. And that was actually came out formally in the diagnostic manual that psychiatrists use to classify psychiatric conditions, the DSM. And it really is important to recognize that there was no new science in making that transition. It was based on ideological principles. And to this day, really, there are many questions about what the underlying cause is of the condition. Again, we can talk about that as well. So that's really historically, and it really began actually in the Netherlands. There was the Dutch had developed an approach really in older individuals for this affirmation and applying that to children. So moving toward aligning the body to conform with the gender identity. And that was brought to the United States again, a little over a decade ago in the early 2000s. There was a prominent endocrinologist, Norm Spack at Harvard, that really was a strong advocate for this, but there are others as well. And I do recall when this all began at that time. At the professional meetings, there was really active discussion going on, recognizing that this was a controversial new approach. Yet the discussion that went on at that time never resolved the concerns that many of the people in my profession had about some of the ideological assumptions that were being made, and really about the very little information that we had about the success of the approach. There was a lot of focus on the immediate effects of relieving that dysphoria, with virtually nothing known about the long-term outcomes and very little known about the consequences of these hormonal treatments. Again, in the process, the process of the discussion was shut down very quickly, where panels were convened to purportedly discuss this, and really the panels were heavily biased for people supporting the affirmation approach, and really shutting down the opportunity to really raise some of the questions that I've continued to raise in this area.
Yeah. Real quick, I want to come back. I want to go to the explaining puberty blockers and cross-sex hormones, and from a medical standpoint. But can you mentioned kind of in passing, I'd love for you to just maybe tease it out just briefly, but the difference between the older term gender identity disorder, and in 2013, right, the new DSM came out, the 5th edition, and now it's called gender dysphoria. So it's still listed in the Manual of Mental Health Disorders. So I would assume it's still technically a mental health disorder, but they've removed the term disorder and now replaced it with dysphoria. Can you unpack maybe why that change in language is actually significant?
Correct. Well, so there are many that would like to have that out of the manual altogether. The dilemma that one has is that one is making the ideological assertion that this is part of the normal human condition, that this is, represents a, spectrum of human diversity. Yet at the same time, one is advocating for pretty significant medical intervention. So you need to justify why the medical profession needs to be engaged in addressing that condition. And really having it listed is the means by which it is justified that insurance companies are pay for this and that clinicians can engage in that. There really is, if you think about it from a logical standpoint, a lot of questions that can be asked about that assertion. If this is normal, what is the reason for having to engage in these interventions that have very significant risks and long-term consequences? So it is shifting it's really stated that it's not a disorder and that they're just addressing the discomfort. Yet I think as one moves forward, logistically they're trying to figure out ways that to really move away from this as even a medical condition, yet still allow patients access to these hormones.
So, and again, you kind of said it in passing, but the three main approaches, I'm sure there's variations, but one would be like a psychosocial approach, right? To look at the psychological aspect of the dysphoria, what might be causing it, what might be flaring it up, and then there's the watchful waiting, which is similar, more just hands off, just let's wait and see what comes about. And then there's the affirmation, gender affirmative approach that wants to says to attempt to align the body with the gender identity through hormones and so on is the best or maybe even only way to relieve the dysphoria. Did I get that largely correct?
Yeah, I think that's correct as far as the various approaches. And I think where they differ in many ways. So they differ in what the scientific premise is, in the intervention that one has, what are the assumptions that we have, and what is the goal of the intervention as well. So that in it's often referred to as the reparative approach, to assist that individual of having the realignment of their gender identity with their biological sex. That would be an intended and desired goal. And again, it's based upon largely, at least in children, on the natural trajectory, but the watch and wait approach really is an unbiased approach. So it really doesn't seek any one particular outcome. It just looks at the likelihood of spontaneous realignment. And again, many people challenge that. But when you actually look at the data, it's a consistent finding. And I think it's, attempts to dismiss evidence that really is on par, if not stronger than the evidence that people use to make the counter argument. So again, the reparative approach has a desire to realign the gender identity with the biological sex. It makes sense from a medical standpoint that if that is the outcome, then one is not obligated to be tethered to the medical establishment for the rest of their life. So they're not subjected to all of the medical risks that are associated with these hormone therapies. And so if you look at outcomes and desired outcomes, even aside from ideology, you have two groups of patients, one that are going to have increased risk of the hormones and another group that is going to be able to go on with life without that exposure. One would think that would be a desirable outcome. But again, it's the ideology that is pushing this forward as the goal is to affirm and have them move forward with the bodily changes. And so in the watch and wait approach, it's also very important to recognize it doesn't mean do nothing. Okay, so that it means that there's not a direction as far as a desired intent of the outcome. It's to support that individual during this process. And that can include psychotherapy to address the issues of depression and anxiety and eating disorders and the other things that are going on. And that really needs to be done in these individuals. And this is best medical practice. We would do this for any patient that walked into the door suffering from depression or anxiety or any of the other what we call comorbidities. So, and then the affirmative approach, the premise, again, as we stated, was that the way it's often stated is that the patient was born in the wrong body, and the assumption is that the mind is correct and the body needs to be changed to align with that. There's a lot of underlying ideology there. There's a lot of things that in the areas of philosophy and other implications as far as how one arrives at that understanding of the human person. But that is why it is pushed for affirmation. Now, the other argument for affirming an individual is the data that shows that the alleviation of that dysphoria will occur in the short run for many of the individuals that are affirmed. And again, going through the different components of that intervention would be helpful. Again, without knowing what the long-term outcomes are going to be.
Well, I really want to get there, the efficacy of medical intervention. But let's start with puberty blockers. For somebody that doesn't even know what that phrase is, can you explain what puberty blockers are and why they would be given to somebody who's experiencing dysphoria?
Yes. So puberty blockers are drugs that are used to halt the normal signals that come from the brain to tell the gonads to work. So that normally during most of childhood, those signals from the brain, specifically the pituitary gland of the brain, are not operating. They're inactivated, and hold on a second. I'm gonna.
That's fine. Yeah. If you need to take the call, I'm sure you got a lot.
No. I'm just trying to figure out how to get it to stop making noise. I'm gonna put it down here. So I'm sorry. Let me start over again. So puberty blockers are a class of drugs that are used to suppress the normal signaling that comes from the brain, the pituitary gland in the brain, to tell the gonads to work. They're drugs that have been used for many years to treat children that have undergone abnormally early puberty. So normally the signals from the brain are secreted in short pulses, and when you give them continuously rather than stimulating the gland, or the gonad, it actually shuts it off. They're also used in adults to treat that are being treated with for cancers, for example, where you want to shut down the function of the gonads to protect them from damage. And we recognize that the condition that we treat in pediatric endocrinology of precocious puberty, the puberty is happening at an abnormally early time point. That is where the drugs have been studied and where they've been approved by our Food and Drug Administration, and where we have quite a bit of experience in using these medications. What is going on in the area of gender dysphoria is that they're now being used to halt normally timed puberty, so occurring at an age where a child would normally go through the bodily changes of puberty, together with the psychological and social changes of adolescence. The medicines themselves have not been studied rigorously in that condition. They've not been approved by the Food and Drug Administration for that purpose. They're used what we call off-label, which is not unique in pediatrics. We do that in many other conditions. But we really have not investigated what the medical consequences of that are. We already know of many things that occur at the time of puberty that are very important. For example, improving the density of one's bones that'll protect them from osteoporosis later in life. It's very critical that puberty occurs for that to happen. So the claims that are made for using puberty blockers in children with gender dysphoria are multifold. The claim is made that it gives some information about in diagnosing the condition, that when somebody starts going through puberty and their body is changing, some children will experience worsening of the dysphoria. It's an unwanted change for them, and that by halting that puberty, we can alleviate that discomfort that one experiences. We'll give them a little bit more time to sort through some of the issues of their gender identity. And it's also claimed that it's safe and fully reversible. And I can say quite a bit about each of those claims. I've already mentioned the safety issue because it's not been studied. So it's really erroneous to say that we know that it's safe. We don't have the information right now to really say that, and we do have things like bone density that are clear risks. There's emerging data right now about the effects of those medications in normal brain development as well. We know that the human brain is not fully developed by the time one reaches adolescence. It actually continues into the early 20s. There's many things that are different in the adolescent brain that lead to very clear observable behaviors that any parent would recognize as far as impulsivity and risk-taking behaviors and the like. But there's also questions about the organization of the brain and memory and spatial processing that there's really not good evidence right now about whether there are effects there. And then, the question or the statement that it's fully reversible needs to be unpacked just a little bit, and I hope we have time to do that. Sure. So what we're talking about is a developmental process. So what one means by saying it's fully reversible is that if you give the hormones, the puberty blockers, you'll shut the signals down. And if you stop giving that drug, those signals will resume. That part is true. Yet you're blocking a developmental process that is time dependent. And so that, again, puberty is only one component of the changes from childhood to adulthood. And there's many other things that are going on socially with the peer groups and in what we term adolescence. So if you halt that process and then resume it, 4, 5, 6 years later, you can't turn back the clock. You've actually impacted the normal development of that child, and all of the consequences of that have not been fully explored. So we cannot say that it's fully safe. We cannot say that it's fully reversible. And all of these claims. And then the other concern that we have, that is that, again, coming back to this understanding that the majority of affected children will have a realignment of their gender identity with their sex, their biological sex. How much is this locking in? By suppressing puberty, locking in that transgender identity and really actually pushing them down that path that at some point may become irreversible. And there is data out there. There's published data in some of the few studies that have been done in this area that rather than having this usual desistance rate, in one study, for example, every single subject in that study went on to get cross-sex hormones, which is a very different outcome. And I know some people argue that the people entered into that study were well vetted and that they were just the ones that were going to go on. But really, there is really no biochemical test or any way that we can determine of those children that experience this condition, which of them will fall into the roughly 85% that will have the realignment of their gender identity with their sex, and the small percentage that will have persistent experience of that gender identity. So, again, many problems, many questions, and this really just needs, from a medical standpoint, to be discussed openly and not. It's part of the normal process that we do in other conditions where we do operate in pediatrics with sometimes with limited information, but we're always willing and really need to, as physicians and scientists, question what's being done and design the proper studies that need to be done to answer those questions.
And everything you've said so far, say in the last 5-10 minutes about blockers in general, is this something that would be fairly basic knowledge to anybody with a degree in endocrinology? And if so, what percentage of endocrinologists, not that you have a survey you've done, but I mean, if this is kind of basic endocrinology, then why is it so widespread that blockers would be freely given? I mean, I want to weigh all the possibilities, but one possibility could be there's just so much ideological pressure that people who know better otherwise are just saying, well, I don't want to lose my job, my degree, I'll just go with this. I'm a little, deep down, I don't feel great about it. But would that be... If I had 10 endocrinologists on here, would they basically say everything you're saying, or would there be diversity of opinion?
So it's important, to note that many of my colleagues, rely very heavily on the Reader's Digest versions, the synopses, the recommendations of professional organizations without really critically evaluating them. I think they're operating under the presumption that they're doing good. I think that the general desire is to help these children, and what they're continually being told is that this is the only way to proceed forward, or that it is beneficial, and haven't had the opportunity to actually look at the data. It's even more concerning than that when we're looking at that. So the guidelines that have been put forward consistently make these claims, that it's safe, reversible, and it doesn't take a lot from a medical practitioner standpoint to recognize everything that I just said. And if it wasn't layered with the ideology, I think there would be general consensus in that area. But that people have not considered the assertions. They accept what people put forward as evidence. In the published literature, a widespread concern is that many of the papers that are being published are not of the rigor that we expect for other conditions. And even more concerning to me is that many times in the title or the abstract of the paper, conclusions will be stated that aren't even supported by the data that's in the paper itself, or at least can be questioned. Or no study is perfect. All studies have limitations. Yeah. Many times the authors will list what those limitations are. How you take that information and apply it to your medical practice is critically important, and that scientists as a whole are generally skeptical. They really constantly question what is being said. Unfortunately, the way medicine is practiced these days, that many people don't delve that deeply into the literature itself. They're not prepared to be critical. Or at least question, what is being said. But I think as physicians, we generally want the best for our patients. That's why we do what we do. We do want to alleviate suffering. We want to minimize risk and maximize benefit. If we're true to that calling, we have an obligation to be able to look more deeply into what's going on. And again, we do this in other areas, and the challenge is to do this in this particular area as well, and be willing to have that dialogue, and not be dismissive of it up front, or to conduct a research study. The traditional way we do research is we try to be as unbiased as we can. I think the reality is that you have to acknowledge that there are underlying biases in everything that we do. But we start with what we call a hypothesis, and we try to look at the evidence for or against that hypothesis. In fact, the way that the research is usually stated is called the null hypothesis. We start with an assumption that there is no difference in a treatment, and we look for evidence that disproves that to show that there is. Many of the papers that are being published in this area are starting with a conclusion and then looking for data to support that conclusion, and they're quite biased in the data that and the presentation of the data that's there, even by looking how they're conducted. So again, it's a problem within our profession. I think it's a problem that could extend well beyond the condition of gender dysphoria if it's applied more broadly. It's a disservice to the patients that we treat, and leads to the potential for proposing therapies that are either not helpful or may in fact be harmful. There actually is a very long history in medicine of things that we used to do thinking we were doing good. And you can look back to the examples of, bloodletting and frontal lobotomies, as examples. And I'm not trying to say that these are the same conditions, but we learn as we go along, and we're willing to look at the data. And we, especially in areas where we have so little information, or where the quality of the information is so limited or poor, we have all the more caution. And let me, just emphasize this. When we talk about those Endocrine Society guidelines that were published in 2009 and revised in 2017, within the guidelines themselves, they acknowledge the poor quality of the evidence. They rate it on a scale, from very high quality evidence to very low evidence. And nearly all of the recommendations that were made in those guidelines were based upon very low evidence. And by definition, that means that there's a high likelihood that as new information becomes available, that the recommendations will change. Some of them are based solely on what they call expert opinion and no data at all. So that, physicians should be cautious in doing this. And there's also a long history of clinical practice guidelines that have been revised, and many times where the recommendations are 180 degrees different than what was previously recommended. I can give an example. Giving hormones to postmenopausal women, is one great example of that. So, again, in that theme, I think that contributes a lot to where the medical profession stands.
So just to sum up puberty blockers, so their puberty blockers might be given as young as 8, 10 years old. Is that roughly 10 to 12 maybe? And so if somebody is experiencing gender dysphoria, all the studies show that an overwhelming majority, the dysphoria relieves itself, after maybe even by means of going through puberty. And yet you mentioned that even a study that people who go on puberty blockers, almost all of them, or one study was like 100% ended up going on to cross-sex hormones and pursuing medical transition. So those are two very divergent statistics, and yeah, I'm sure that's interpreted different ways. So let's move, I guess, to cross-sex hormones. So if somebody goes on blockers, overwhelming majority will end up going on cross-sex hormones. So can you explain what cross-sex hormones are and what does the science say about the risks and benefits of that?
Happy to do so. So what we mean by cross-sex hormones are, for example, giving testosterone to a biological female that desires to have the bodily characteristics of a male, or giving estrogen to a biological male that desires to appear female. And these are it's important to know that both males and females have both hormones. So all men have both estrogen and testosterone, and all women have testosterone and estrogen. It's the relative amounts of those hormones that differ, and we have many conditions that we treat as endocrinologists where those hormone levels are inappropriate for one's biological sex. A great example of that is the treatment of too much androgen or male hormone, testosterone in females that have polycystic ovary syndrome, and very well documented that there are very significant risks as far as cardiovascular risk, metabolic risk associated with that. And the difference is, what the patient's desire is. It's not the difference in what the physiological or pathophysiological effect of those hormones are going to be. So if you give testosterone to a biological female, you will have impairment of the normal functioning of the female reproductive system. So the ovaries will not function as they normally do. Fertility will be impaired. You'll get virilization, so growth of hair in places where you are desiring to have that to occur. And you have a whole host of changes induced. So these hormones themselves act throughout the body. They don't just act on the reproductive system. Males and females genetically being determined at the time of fertilization. The differences between males and females occur in every nucleated cell of the body, and the programming of those cells is geared toward what would be expected for that biological sex. So giving testosterone to a female is not equivalent to giving that same hormone to a male, and vice versa. And so, as we think about the way that these hormones are given, many times, for example, in females females desire to appear as males, they're achieving testosterone levels that are orders of magnitude higher than they would ever see, even in conditions like polycystic ovary disease, and really reach the level that we would see in androgen-secreting tumors. So what are the consequences of that? Some of them we know, some of them we're still trying to unpack, and some of them we're very likely to discover down the road, are going to be very significant. So there's clearly changes that occur. For example, I'll just give you a couple of them. It's very well known if you give estrogen to a biological male that you have about a 5-fold increase in incidence of stroke. Okay, so that, which people can die from, and they can have significant neurologic complications of that are going to be lifelong. We know that there's an increased risk of metabolic changes, including insulin resistance and diabetes, in giving these cross-sex hormones. And many of the outcomes as far as heart attacks leading to death are going to take many years. And so since we're starting these in children at a young age, we haven't even reached the point where we're going to fully understand what's going on. But already the information is coming out that they're not safe in that respect. There's a lot of desire to make the argument that they are safe. But it's not unexpected. So in any medicine that we give, there's going to be risks and benefits. Yeah. Really, the question is, are the risks acceptable in relation to what the benefit is? And the argument that's often made is that if they don't receive these hormones, they're going to commit suicide. Right. So then, they're going to be dead. And so therefore, we can tolerate all of these other outcomes because they're not committing suicide.
Can you speak to that? Because that's very, very widespread. The phrase, do you want an alive daughter or a dead son? You hear that.
Right.
I hear it a lot, actually. So if I could hear somebody saying, yeah, I understand the risk, but there's things we do to fight cancer, and we understand the risk, but I'd rather not die of cancer, so I don't mind having other health side effects. So can you speak to the kind of like suicidality versus the health risks and the mitigation there?
And this is another example of a desire to do good by not really critically evaluating what the evidence is. So really, in treating children, we do not have that long-term data. It does not exist right now. The largest study that's going on right now is what's called an observational study. So these children are being treated and they're being followed over time to see what the outcome is. They really don't have any hypothesis. They're just trying to figure out what's going to happen. Well, where we do have evidence is in the adult population. So people that were started later, after they've gone through puberty and early adulthood or later. And there's a couple of very important studies that have come out that really need to raise questions about whether what we're doing is truly beneficial in that regard with suicide. One of the ones that is often quoted is a Swedish study that was published in 2011. The Swedish healthcare system and the government itself is such that they collect an inordinate amount of data on every single person in the country so that it's not a biased sample, which is another problem with many of the research studies that are done. So we get a population-based sample, and they look several decades after affirming interventions were performed, so both cross-sex hormones and with or without surgery, and looked at what the outcome was. Now, this wasn't a controlled study, so that it is not possible from that study to say whether that intervention changed what the outcome would have been otherwise. But what the data shows is that the rates of completed suicide are still 19-fold above the background population. So what one can say with confidence is that it didn't fix the problem. There's still ongoing issues. Now, what many people will say is the reason for that is that they weren't able to socially pass as the desired sexual appearance, and they had many areas of social stigma. And those are reasonable hypotheses. We can ask those questions, but in the end, that data does not show that it fixed the problem. So this claim that it's going to prevent suicide is not supported by that information. A more recent paper came out where they looked at mental health outcomes after cross-sex hormones in surgery. And this came out just in the past year. The conclusion of the paper as it was published, it was a paper by a lead author named Brandstrom, was that surgery, the gender-affirming surgery, improved mental health. When the data was analyzed, it was clear that there were many problems with the way the data was analyzed. And even before saying that, they claimed in the paper initially and showed that the cross-sex hormones themselves didn't affect mental health. So that was already shown not to be beneficial. Because of challenges by many different investigators who looked at that data, they reanalyzed the data. They didn't retract the paper. They just made the claim that they probably overstated their claims.
Were you one of the ones? I know Will Malone wrote a critique of it, and I think you did too, right? Or several endocrinologists.
Several people did, and not all of them got their critiques, published. But in the end, what that study showed is that the affirmative approach did not change. I taught by affirmative approach, cross-sex hormones in gender-affirming surgeries did not alter mental health outcomes in the patients that were studied. So basically, it showed that it wasn't having the benefit that they were purporting that it had. Now, those are only 2 studies. There's other studies out there as well, and there's a need, to be very rigorous in looking at this data. Another interesting observation is that, again, because these are not controlled studies, comparing patients that have other issues unrelated to gender dysphoria and what is the rate of suicide by depression alone, independent of gender dysphoria or some of these other comorbidities that we have. And when you actually are objectively looking at this patient population, they're at very high risk of attempted and completed suicide just by having depression and anxiety. And so, and then, trying to sort out how much of that psychological or psychiatric comorbidity preceded the gender identity. So it's not really established, which is the chicken or the egg is the way that we often say it. A lot of questions that can be asked about what's underlying that. And then that leads to a corollary, a question, that what is the best way to approach the depression and the anxiety and the eating disorders and all these other things that are going on? And is that sufficient to be able to prevent that suicide outcome? So there's many questions that can be asked from a rigorous scientific standpoint. There's data that's already available that indicates, that this whole question of suicidality is not necessarily dependent upon affirmation. There are really an absence of rigorous studies that are being done looking at modern psychological approaches. And again, one of the reasons why that is that there are some that make the claim that psychological approaches are harmful and they don't work. And they make that categorically by citing papers from decades in the past using outdated psychological methods, many of them merely case reports, and many of those actual studies that they cite do show benefit for some patients. They dismiss that completely. They just say it's categorically harmful and not helpful. What has not been done is to apply modern approaches to psychotherapy. And again, I'm an endocrinologist, but know enough in treating other things like anxiety and depression in my patients with diabetes, for example, to know the benefit of being able to do that. Even to go so far as to when a patient comes in requesting these interventions, to explore in detail all of the underlying psychosocial dynamics that are going on, all of the preceding components of psychological health, as contributing to this desire to receive this intervention. Is not given the weight that it normally would or should in these conditions.
And that's a great overview. And I've seen it happening, especially in Canada, in the U.S. and in Australia and other places where any kind of psychosocial attempt or psychoanalysis, psychological attempt to address the dysphoria is being labeled as conversion therapy. And so you have policies being enacted. I think some are even put into place to where you'll have the phrase, it is illegal to try to change somebody's sexual orientation or gender identity. Those are two very different things. Another way of saying change someone's gender identity, you could say the same thing in different ways, saying helping somebody to live in their body, accept their body, which in every other field that I'm aware of is what we do. Like if somebody has some kind of body dysmorphia, I know that's a broad category, but we try to address, we try to help them live into that. Gender dysphoria is the only one that I'm aware of where it's the exact opposite is true in some attempts. Can you? Are you seeing that kind of subtle correlation between sexual orientation and gender identity change being labeled conversion therapy? And I don't know how this is being passed because these are seem very different to me. But
yeah, in many respects, it's not so subtle. I think it's a directed attempt. And again, it's important to be very precise in the words that we use and to be accurate in what we're doing. And I think this is certainly the people that have underlying ideological desires want to be able to use that language in a way to achieve a desired outcome. What is being conflated are things that were done in a different condition in a different era. I think that when using the word conversion therapy denotes many things that I think all physicians, would say, that's approaches that nobody would support. That's very different than the psychological investigation and support for people who have gender dysphoria. And really, I think it is an intentional use of that word, and it's an intentional desire to conflate different conditions to be able to really suppress the conversation that needs to go on. You may note that I use the term reparative therapy. Even that is, what are we actually trying to do? So that if you talk about converting, we're talking about what one's identity is in their gender, of who they are as male or female, in relation to their biological sex. So one could, make the argument of in the opposite direction that by altering the appearance of the body, one is converting oneself, to a different phenotype or appearance. So I think I think you touched upon things that are out there in the dialogue, and this is where, from the really important scientific and medical discussion, where we need to be very objective, we need to really maintain, focus on what our goals are in the area of best medical practice, to really try to, at least we need to acknowledge where the biases are, but expose the ideology that's behind this, because it's not helpful in the dialogue, so that people can disagree about the nature of the human person, from a philosophical or theological standpoint. But what we're talking about here is what is best medical practice. What are we going to be able to do to have the best benefit for the individual that comes for our care, minimizing the risk and maximizing benefit.
We have just a couple more minutes, Paul, and I don't want to keep you past the hour, but can you give just a last word of advice to parents? I know there's probably a lot of parents listening to this that have kids that are, maybe identifying, exploring, or maybe wanting to get on hormones or whatever. What would be your advice to specifically to parents who are in this situation?
That's an excellent question, and a very important way to kind of wrap up this discussion, because very frequently, parents are seeking answers. I mean, parents in general, in loving their children, want to do the best for them. Many of them will have very significant questions about what is being offered as far as the best treatment. They'll intuitively have reservations about that. They're often not in a position of knowledge or authority to really challenge or question what their practitioners are telling them. I think just having the discussion that we're having today, I think is helpful to at least bring to the surface, bring to light that there are so many questions that are going on. The way it needs to be presented to parents to be very true to what we're actually doing is we're engaging in an experiment, a very large experiment with an unknown outcome. And in other areas of medicine, when we engage in experimentation, we acknowledge that and try to put up safeguards, to really help. Now, from the parent standpoint, I can only reinforce what I think most parents will do. I mean, to really, even though they're confused, they're anxious, they're wanting to do the best for their children, to love their children, to accept them unconditionally for who they are. And as any parent would do in other areas, that doesn't mean they can do anything that they want. Parents in other areas will set very clear boundaries. They'll have conversations about what is acceptable and not acceptable within the family. There are things that parents will say no to where the child desperately desires, to have to drink alcohol or smoke or put their hand on a hot stove. So the parents, just to love their children, to accept them for who they are, yet actually, still seek out help that will have long-term benefit for them.
Paul, I just can't thank you enough for all of this. A lot to digest, and I'll post these studies in the show notes. They are important, the ones you mentioned a few minutes ago. So, thank you so much for sharing, and many blessings on your continued work and wisdom in this really important area.
Well, it's my pleasure. Thank you.